Well, good evening, everybody, and thank you for joining us. I'm going to be talking to you this evening about elbow instability and tennis elbow. So you'll be familiar with tennis elbow. I'm going to try and give you some practical tips which I hope will be helpful to help you confirm the diagnosis. I'm also going to talk to you a little bit about some of the treatment options and current controversies surrounding this. Obviously, in the world of COVID, you have to be safe. So I want to try and help you make a rapid diagnosis as quick as I can to try and keep patients moving through your clinics, and also to talk to you about a little bit of slightly more current perception that some of our refractory tennis elbows may be due to subtle elbow instability. So just something to think about for the patients you may be seeing. So as you will know, tennis elbow is a colloquial term we use to describe lateral epicondylitis. So this is a condition that isn't actually an inflammatory condition, it's a degenerate condition. So that's a slight misnomer, because everything in medicine is an itis till proven otherwise. We'll get through it together, and I'm hoping to be able to help make this a bit easier for those of you who may be less familiar with lateral elbow pain to confirm the diagnosis. The history is pretty classic. It's actually quite rare that patients who are doing racket sports complain of a tennis elbow. I very rarely actually see a tennis elbow from a tennis player. I tend to see it far more often actually with golfers or cricketers, but it does exist. You get a classic aching pain of the lateral aspect of the forearm, which is worse on exertion. It can be very difficult lifting things, but the one sign which I think is probably very relevant in our current Zoom existence and Teams existence is what we call the laptop test. So most people will now have a laptop bag to carry a laptop of some description. And classically, when you have a proper tennis elbow that's symptomatic, when you go and pick that computer up out of the bag, it's very sore, and patients will often flinch and go, "Ooh, that's it." So the laptop test isn't yet a fully described sign, but it's a practically very useful thing in the history. And of course, the reason patients come to see us is usually because it disturbs their sleep, and that can be quite disabling and also quite fatiguing for many patients. So the next slide has got a video, which I'm hoping the sound from the video won't play for you, but I'm hoping to talk you through the movements. So I will show this and make sure that is silenced. So this is how we are kind of doing our examinations in the COVID world. So in this scenario, my subject is wearing a face mask. I'm obviously wearing a face mask as well, with an apron and gloves. And you need to have them fully exposed. Basic principle of examination is that you need to know that you can see both sides. You're looking for signs of any scars, any asymmetry, any obvious muscle wasting, and so on. I'm just going to go back to that slide if I can to try and get the rest of the video for you. And so when we are looking at the patient, obviously the problem that I'm finding in my practice now is that you can't see patients' faces when you are talking to them as well, because they have face masks on. And so it's very helpful just to get them to tell you, is it hurting when I'm doing that for you? Because they don't always show that. This particular example here, I'm showing the patient is putting their arms out. The human eye spots asymmetry much better when you do both things together. And this is a common thing that patients will do when you ask them to pronate and supinate. They move their shoulders out. Don't let them, because they may be masking some pain in the lateral compartment of their forearm. So then we go through our basic checks. This is what's called a flexion catch chest. Then you've got the mid-range and then the extension catch. So you're just looking for signs and symptoms of pain in those different areas. The significance of that is that a mid-range pain would suggest an arthritic problem, whereas extremes can be more easily dealt with. We've just shown the grip grind test for radiocapitellar pain. Now, this is the key one that's coming up now. So when you're testing for lateral epicondylitis, I'm just getting the patient to turn to the camera, so hopefully you can see them on your screens. I'm palpating over the lateral epicondyle with one hand, and then I'm getting them to resist with downward pressure, holding an extension. Now, classically, that reproduces their pain, but to confirm it is actually a positive tennis elbow, you then get them to flex their elbow to resist in that position. When you flex the elbow, you take the strain off the ECRB, which is the involved tendon, and therefore it should improve when the patient goes into flexion. So I'll just go over that again, because that's a really important distinction. When they have the positive pain in extension over the lateral part of the elbow, if it's a tennis elbow, it should improve in flexion. If it doesn't improve in flexion, you should be a little bit suspicious. It doesn't quite fit. So you'll know a lot about the treatment for how to manage tennis elbows. It includes injection therapy and it includes physiotherapy. The main learning point that I would like to really emphasize to anybody listening this evening is that please do not inject steroids for tennis elbows. And this is very, very important. The reason why I say this is irrespective of the risks of steroid in a pandemic, and again, you'll be aware that there is a theoretical increased risk of reducing someone's immunity to viruses during the first 72 hours after injection. And therefore, there is a theoretical risk that you could become an asymptomatic super spreader and not know it. So there's a public health aspect of steroid injections, which is why our orthopedic specialist societies have recommended we avoid them if we possibly can. But the thing that's specific to tennis elbows is that we know from quite significant body of literature in the elbow world that it actually prolongs your symptoms. So it may make you temporarily better, so they'll be happy initially. But the natural history of a tennis elbow is it will get better on its own after about 12 months if you don't do anything. Unfortunately, with steroid injections, it often takes longer than 12 months and actually make the patient suffer for a longer period of time. So I would not recommend that you do steroid injections for tennis elbows. It's very tempting, and I know you will get some patients who will be begging you to have them done. There is only one situation where I think you can reasonably justify doing a steroid injection, because you should never say never, and that is in an informed patient who has a very specific time frame to do something. So, for example, if you had an international sportsman in a World Cup, for example, or something like that, where it's only going to come around once in their lifetime, and you have to do something to get them out of pain as quick as you can, accepting that it will make it worse in the long run, and they understand that, then there may be a role for it in that kind of scenario, but that is extremely rare. So as a general rule of thumb, please do resist the temptation to inject these patients with steroid. That is my overwhelming message. And there's a picture of some of the problems you can get with the depigmentation, which is obviously quite cosmetically unappealing. This was actually a cricketer patient of mine who'd had multiple injections overseas and didn't really like the appearance of his elbow. So one of the things we're very keen on at 108 is to do biological treatments to avoid, limiting what we can do for patients in terms of their future options. So we don't burn bridges, and again, much like the osteitis condition that we've had described so beautifully by Professor Lee this evening, I use platelet-rich plasma as well, selectively for patients with a refractory tennis elbow. And in my personal series, I have had a very good success rate with this. The basic principle behind it is you confirm the diagnosis with the appropriate history and examinations I've described. Quite often the patients will have had a course of physiotherapy of some description before they've come to me, but if they haven't, then I do recommend they have that. And then if they decide to proceed, then I will do an ultrasound guided injection with PRP into their ECRB. And this is something that I do as a half an hour sort of in-out procedure with one injection. In my personal series, I've never had to do more than 2 injections for any one patient, and of them, only 2 of them have had to have 2. And I've never had to convert to surgery from anybody from a PRP injection. So far, I've not yet not had a good result with PRP injections. But the question is, well, okay, fine, that's all well and good to tell me to do PRP injections, but how do I know how to make them do very well? Well, you have to counsel your patients about the do's and don'ts to make it work. So you have to stack the odds in your favor. So it's really important that those of you who are managing patients with tennis elbows who are having platelet-rich plasma injections, or for other conditions for that matter where they've had a PRP, they must avoid non-steroidal anti-inflammatory drugs for 6 weeks afterwards. Otherwise, the biological effects of the PRP can't work, because the drugs will then act to counteract the effect of the PRP. So please make sure they're aware of that. I also make sure I counsel my tennis elbow patients to advise them that you will need to wear a wrist splint afterwards, because even though the condition is a condition that affects the elbow, the actual muscles move the wrist. So in order to give it a chance to rest, you don't immobilize the elbow afterwards, you immobilize the wrist. And that's something that's worth spending a little bit of time with your patients about, so that they will understand and buy into it. You also need to tell them to avoid any heavy lifting for between 4 to 6 weeks afterwards. And again, this comes back to what was described previously by Professor Lee with regards to the collagen turnover time. In practice, one cycle is 3 weeks for collagen turnover. 2 cycles is 6 weeks. If someone's got a more sedentary job, you can probably get them going at 4 weeks. But if someone's going to do very heavy physical work, I'd suggest that we stick with 6 weeks. And you have to set the realistic expectations for your patients from the beginning, and they'll generally do very, very well. So a little brief description about those patients that may be looking for a surgical option. These can broadly be described into an open procedure or a keyhole procedure. Open procedures are very quick and can be done under local anaesthesia in a clinic setting. It's very safe, they have a very high success rate, and it takes about 10 to 12 weeks, so about 3 months to get back to heavy loading. The keyhole technique does require an anaesthetic of some sort. It has to be done in an operating theatre rather than a clinic. It is potentially more risky anatomically in terms of the ulnar nerve in particular. I must admit, I've never had an ulnar nerve injury, and I hope to never have one whilst doing an arthroscopy. I've done more than 90 of these now, but it is no doubt far more risky anatomically than an open procedure. I've had a higher success rate with arthroscopic than open. That may reflect the fact that in the last 6 years I've been doing arthroscopic rather than open. So in my learning curve as a junior surgeon, that may explain that. The recovery time is significantly quicker for arthroscopic. It takes about 3 to 4 weeks rather than the 10 to 12 weeks. The reason for that is that the basic principle in the operation is you cut out the diseased part of the tendon. When you do it as an open procedure, you have to start from the skin and work your way down. And the actual diseased tendon, which is the ECRB, sits underneath the EDC. So if you have to cut through a lot of the EDC to get to the ECRB, then it takes a while to recover. Sorry, I know that's a big mouthful. Whereas if you do it arthroscopically, so from inside out, you don't need to make such a big hole in the EDC. So you can actually take out the diseased bit of tendon whilst doing a fairly small violation of the actual overlying tendon, which is why the recovery is quicker. The other significant advantage for arthroscopic surgery, in my opinion, is that it allows you to treat other concurrent pathology. However, everything has changed now because we're in the world of COVID, aren't we? And so I have to be honest, since COVID has become a real issue, I'm now not doing as many arthroscopic tennis elbow releases as I used to. The simple reason being that if I'm convinced that clinically the diagnosis is a tennis elbow and the patient understands the risk, I can do this under a local anaesthetic procedure, in out same day. You've got no risk of having your lungs ventilated by a machine, so you've got less risk if you contract COVID, and it's fairly safe. And also the other thing that you'll be aware of is that the national state of the NHS is that they've taken over pretty much almost all theatre availability. So getting someone into an operating theatre for essentially a quality of life operation is very hard to do when you've got patients with cancers and other more clinically urgent conditions that require that theatre time at a premium. So that's the reason why currently my practice is shifting more towards an open tennis elbow release. Now, one of the things I wanted to talk to you about was to be aware that you'll have patients that you've treated for tennis elbows, they've engaged religiously with their physiotherapy, they've had perhaps a PRP injection, but they're still not quite right. So it's important to be aware that we are now beginning to appreciate that there is some subtle instability for refractory tennis elbow patients. But you can't often find this when you examine them, because when patients are awake and have their normal muscle tone, it doesn't really show very easily. So you sometimes have to do what's called an EUA, or an examination under anaesthesia, to find this. So this is an example of a case that I wanted to show you. This is a patient who is in his 40s. He's an ex-military officer involved in one of our more, shall we say, covert groups, who had been diagnosed as a tennis elbow, which hadn't settled down. And we ended up having to do an EUA, but being prepared to then deal with what we found. This is the video of his examination under anaesthesia. And what I hope this will show you, I'll try and take that sound away for you. And you can see that the elbow is actually popping in and out. And so we ended up doing a stabilization procedure on this gentleman, which is what that scar's from. So he actually had not a tennis elbow on its own, he actually had subtle elbow instability, which was driving his tennis elbow. And that was why we ended up stabilizing him. And because of the fact that he was the job that he had, we ended up using an allograft so that he didn't have to sacrifice any of his own hamstring tendons to do the repair. and he's had a very good functional result, which I'm sure you can see. The other thing I was just going to mention was that occasionally, if you do an elbow arthroscopy in these patients as part of your assessment, you will see that they have arthritis on the lateral aspect of their elbows, and they can look a little bit like this. And on that picture, which I don't know how well you can see it, but it essentially looks a little bit like the moon landing. This was actually a case that I was doing last week, and he'd had a suspected lateral elbow pain, not really fitting any of the criteria. So sometimes you do have to just do an exploratory look inside, and you'll find these kind of conditions. And that comes back to another option then. So how would you potentially treat that? Well, there are biological treatments, and there are some of our more fat cell-based treatments that you can use for these conditions, but this is something to be discussed in more detail on another occasion. So that is the end of my talk this evening. I hope it's been helpful for you. I'm very, very grateful to Yewlett for hosting this for us, and I'm delighted that you all tuned in. Thank you very much for your attention. If there are any questions, please do send them through to us, and we will get back to you as best as we can, as soon as possible. And please, everybody, do stay safe out there. Thank you very much for your attention.